the presentation. Till now there is a technical issue, and we'll proceed until the presentation will be presented. Our topic today is about physical therapy for von Willebrand disease. For people who doesn't know von Willebrand disease, it is a bleeding disorder. It is the most common bleeding disorder, but it is the least to be diagnosed. Our objectives today is to know the historical background of von Willebrand disease, to understand what is von Willebrand factor, to discuss the different classifications of von Willebrand disease, to understand and know the clinical manifestations, and know the medical management and physical therapy management of von Willebrand disease. As we mentioned, it is the most common but the least to be diagnosed, and it estimates that it affects 101% of all US populations. In some paper, it mentioned that it affects about 1 in each 100 people, and in others, it affects 1 in each 10,000 people. This gap is due to the less documentations and assured diagnosis of von Willebrand disease. Historically, in 1926, the Finnish physician Erik von Willebrand described a new blood disorder. He named it pseudo-hereditary hemophilia, but unfortunately, he couldn't identify the factor affecting this disease. Later, by many years, this factor has been identified, and it's named after his name, and this factor now is known as von Willebrand factor. Von Willebrand factor is multifunctional and multi-memeric glycoprotein that is synthesized in the endotheliums. The von Willebrand factor consists of similar subunits and the size of the glycoprotein receptors. The adhesive activity of the von Willebrand factor depends mainly on the size of the multimers. Von Willebrand factors plays important role in primary and secondary hemostasis. Also, it acts as a mediator for adhesions, carrier coagulation, and it involves in angiogenesis and inflammatory process, and it helps in the coagulation of factor VIII, which is very important. As a definition of the von Willebrand disease itself, as we said, it is a bleeding disorder. It can be inherited or can be acquired. And the acquired von Willebrand disease came as autoimmune inheritance reaction due to people having cardiac defects, some symptoms of cancer, autoimmune disease, or after certain drugs such as valproic acids. As a classification, as we said, it can be acquired or can be inherited. The inherited has 3 different classifications. The first classification is it is come from autosomal recessive or come from autosomal dominant. The second classification is it is type 1 or type 2 or it's type 3. The last thing is it come from, for the sound, I'm sorry. Is it come from qualitative defects or quantitative defects? If we merge the 3 inherited classifications, we'll find that the inherited von Willebrand disease is divided into von Willebrand from qualitative defects and von Willebrand with quantitative defects. The quantitative is divided into type 1 and type 2, while in the other side, the qualitative is divided only in type 2, which is subdivided into type 2A, type 2B, type 2M for multimer, and type 2N for non-MD. Type 1 is dominant, type 3 is recessive, and type 2 is dominant. Type 1, which is the most common, it affects about 75% of people with von Willebrand disease. It's considered to be the mildest and is the least to be diagnosed. And it's the hardest to be diagnosed as its only manifestation appear after surgery or after dental loss. Type 2 is the second most common von Willebrand disease, affecting only 25% of the Willebrand factor.
As we mentioned, it's autosomal dominant and it's known to be qualitative defect, as we mentioned. That means there is enough von Willebrand factor in the blood, but there is a problem in its function. As we said, it's divided into 2A, 2B, 2M, and 2N. Finally, type 3, which is the most aggressive type, but luckily for us, it is the less to be known and common, and that's come because it's the autosomal type only in von Willebrand disease. It's characterized by the total absence of the von Willebrand factor in the blood, and its manifestation is bleeding in tissues, joints, and muscles and gut in some cases. For clinical manifestations, the most clinical manifestations are nasal hemorrhage, dental and oral cavity hemorrhage, prolonged wound healing, menorrhea, and gastrointestinal hemorrhage with severe types, which is type 3, as we said. The most common manifestations for pediatric population are umbilical stump hemorrhage, cephalic hematoma, sheath hematoma, and conjunctival hemorrhage, and oculocircumcised hemorrhage.
Described the pseudohemophilia, as he mentioned, which is now known as von Willebrand disease. This is the von Willebrand factor glycoprotein. This is a types, which is autosomal dominant and autosomal recessive. This is a merged classification. Okay, you can pass it. That's it. Von Willebrand disease is known to be the most common, as we said, and it's hardest to be diagnosed. Why? Because, as we said, why it's hard? Because laboratory tests such as CBC, activated partial thromboplastic type, prothrombin type, and fibrinogen tests always appear in normal levels when are tested, so von Willebrand not easily to be diagnosed. There is some specified laboratory test should be done for its diagnosis, such as von Willebrand antigen, von Willebrand resistant cofactor activity, factor VIII activity, or the ratio between the von Willebrand resin and von Willebrand antigen ratio. For medical diagnosis, it's based on the severity. As we said, type 1 and type 2 are less severe, and type 3 is the most severe. So, according to the severity, is the medical management. So, some physicians describe desmopressin, plasma-derived von Willebrand, and factor VIII concentrates, anticoagulants, and hormonal therapy. Our role as physical therapists is to promote the functional skills in pediatric and adults with von Willebrand disease, especially that the National Hemophilia Foundation form a group, they call it MAZAC, creating a guidelines for people with hemophilia and von Willebrand disease. According to this framework, it's stated that physical therapy has a crucial role in joint and muscle rehabilitation and soft tissue injuries and hemoarthrosis. And that's also considered how the type has affecting the aerial activities, affecting joint range of motion, or affecting the muscles. First, as a physical therapist, you must take the history, and it is personal history, family history, the bleeding history in these diseases,
medical and previous surgical history, pain history is very important, and ADL concerns and occupational concerns. We must know these two target joints. The most common target joints in vulvar disease, such as hemophilia, are knees, elbows, ankles, hip, and shoulders. First, for your subjective assessment, you must make palpation at rest and during active range of motion. See if there is any edema and see if there is any increasing in temperature. Must take a growth management for assessing edema and muscle atrophy. Know that enjoy and feel via passive range of motion, manual muscle testing, muscle flexibility test, and sensation and proprioception. The objective assessments include balance and fall assessment, postural alignment, assessment of functional activities, gait analysis, neuromotor assessment, and musculoskeletal ultrasound. That's recommended that each stage that the joint or the muscle have, whether it's acute, subacute, or chronic, have its special designed physical therapy program suggested for it. So the management is, according to Mazak, is divided into three categories. The first category is management of the muscles, all muscles except iliopsoas. Iliopsoas only have its own suggested program, and lastly, management of the joints. First, let's see if the muscle bleed and it's not iliopsoas. What we should do? We must understand the main problem we have in acute phase is persistence of pain with movement. Our suggested physical therapy program is rise, as we know, rest, eyes, compression, and elevation. Tense for pain, splinting, no active range of motion, and no compression if there is any neuromuscular symptoms appears. In subacute, there will be limitation in ADL activities, but without increasing pain from baseline. And we should make a physical therapy program that has splinting and assistive device to the limit activity, to touching in weight bearing, isometric contraction, positioning, active range of motion, and tense. In the chronic phase, there is ADL limitation, but without any pain. So we must do full weight bearing without assistive devices, positional stretching, active range of motion, unrestricted lifting, and re-evaluation. Other considerations may include kinesiotaping. Some precautions must take in concern using heat modalities. In iliopsoas, the main problems in acute stage is such as any type of muscle. There is pain persisted at rest, and there should be vein rest to touch with bearing with household mobility, resting, and opposite limb ankle bump with vein avoidance as a physical therapy program. The second physical therapy program in subacute phase is toe touching without increasing any pain, isometric contraction, active range of motion, and positioning. Finally, in chronic stage, full weight bearing without any assistance, positional stretching for prone and active range of motion exercises. There's a very important precaution should be done when you deal with iliopsoas, which is monitor if there is any femoral nerve pulse. Finally, if the joint bleeds. The main problem is persistence of pain in rest or in motion, where we must do rise, splinting, and prevent any weight bearing acute stage. In subacute stage, we should continue rise after exerting splinting, night resting splint for protection, begin progressive weight bearing activity, modification to avoid pain, and pain-free, gentle, active range of motion. Finally, in chronic stage, we should use dynamic splinting to increase range of motion. We must do active range of motion, strengthening exercises such as open chain, closed chain, and resistant band, proprioceptive training, gentle range of joint mobilization, modifying muscular activity. The precaution to monitor the nerve compression, to avoid any aggression to return exercise or ADL activities too early, and no return to any sport until there is a full pain-free range of motion.